Hello, and welcome to the Feeling Good podcast, where you can learn powerful techniques to change the way you feel. I am your host, Dr. Rhonda Borowski, and joining me here in the Murrieta studio is Dr. David Burns. Dr. Burns is a pioneer in the development of cognitive behavioral therapy and the creator of the new team therapy. He is the author of Feeling Good, which has sold over 5 million copies in the United States and has been translated into over 30 languages. His latest book, Feeling Great, contains powerful new techniques that make rapid recovery possible for many people struggling with depression and anxiety. Dr. Burns is currently an emeritus adjunct professor of clinical psychiatry at Stanford University School of Medicine.
Hello, Rhonda.
Hello, David, and welcome to all of our listeners around the country, around the world, throughout the galaxy. This is the Feeling Good podcast, and this episode 446. We have a really special guest today. I've been so happy to be interacting with her. She's a pediatric endocrinologist. Her name is Rachel Sewell, and let me tell you a little bit about her. She identifies as a proud member of the LGBTQ community. Dr. Sewell attended Carnegie Mellon University in Pittsburgh as an undergraduate, and she attended the University of Colorado School of Medicine. She did her residency and her fellowship at Children's Hospital Colorado, which is affiliated with the University of Colorado School of Medicine. She's a board-certified pediatrician specializing in pediatric endocrinology, and her career as a pediatric endocrinologist focuses on providing high-quality care to transgender and gender-diverse TGD youth and patients with differences of sex development. She's currently a clinical assistant professor of pediatric endocrinology at Stanford University School of Medicine. Welcome, Rachel.
Welcome, Rachel. And I'll just add that I met Rachel, met you just, I don't know, must have been about 3 weeks ago or 4 weeks ago on one of our Sunday hikes, and was just delighted to get to know you and said, hey, maybe you'd want to come on our podcast and tell people what you do and also how you're feeling these days, because it's a period of great disruption in our culture and a lot of anxiety and a lot of suffering and struggles. And I thought your story was an incredibly important one to share with our listeners.
Well, thank you so much, both of you, for having me here. It really is a pleasure to be speaking to you and all of your listeners on Feeling Good. And I'm so excited to be able to share my experience as a clinical physician who has the opportunity to work with this very vulnerable population, especially in a time when our political climate and just cultural climate is so divisive, and to share what that has been like for me. Like Rhonda was saying, I am a recently graduated pediatric endocrinologist, and I have the great opportunity to work with an amazing population. I provide medically necessary care to transgender and gender diverse youth. Again, that can be, and often is shortened to TGD, but so I provide care to that patient population, as well as patients with differences of sex development who may identify as intersex. And it's just a really intense and difficult time to be not only practicing as a physician in this space, but to be somebody who is having that lived experience. So thank you for having me on here.
Well, we're so pleased to have you. And one of the things I hope we'll learn about today is that some of the joys and also some of the challenges and dark moments of the work you do. I know that the work that Rhonda and I do, working with people who are depressed and kind of feeling worthless, is really usually something of great joy to bring happiness and laughter into the lives of people who've been, say, sobbing and feeling worthless at the start of a session and feeling joy at the end. And it's a great privilege and a tremendous experience. But there's a dark side to our profession, is when someone becomes kind of suicidal, and you're doing your best to save that person's life, but living in fear that you get a call from the family or the coroner in the middle of the night that that person has has died, and that can create a tremendous anxiety and anger and pain. And I'm sure that the details of your work, Rachel, are radically different, but I can imagine that the intense emotions on both sides of the spectrum are equally intense, if not sometimes even more so.
Yeah, I would definitely say that there are very extreme highs and very extreme lows. I think one of the toughest things that I've experienced recently has been just how much fear and ignorance there is. I personally really emphasize medical education and view education as one of the best and most direct forms of advocacy. And so to see the misinformation and the disinformation that is being spread about transgender and gender diverse youth, and how it impacts the conversation and how people talk about these young individuals who are just doing their best to make their way through our world. I think that it results in, similar to what you experience, a lot of depression and as well as other mental health concerns, increased suicidality. We know that transgender and gender diverse folks are at much higher risk of not only having suicidal ideation, but moving forward with any form of suicidal attempt. And so it's definitely something that is constantly on my mind and something that I watch for and screen for in my patient population.
Rachel, when you went to medical school, did you have the idea of becoming a pediatrician? And then how did you move from pediatrician to pediatric endocrinology?
Great question. I did not know what I wanted to do going into medicine. I knew I wanted to be the one making the diagnosis and starting that process. That was about where I was going. I actually started off working in the emergency room, and I had a fantastic clinical preceptor who pulled me aside after several overnight shifts and said, Rachel, do you notice how whenever there is a teenager or a pediatric patient who comes in, and mind you, I was on the adult side, but every now and then they would come in and she would say, have you recognized how much time you spend with them and just how excited you are? And it was like this light bulb went off of, oh yes, I love working with children. I want to help them feel better and have them be my patients. And so that transition was very quick. I quickly shifted into having my training focus and emphasize pediatric care. And then there were a couple of really formative moments that played a big role in my decision to pursue endocrinology. I knew that no matter what I did, I was going to serve as a vocal advocate for LGBTQ patients, as well as their health and well-being and the care that is provided to them. But I didn't really know what that was going to look like. I actually had one of my medical school compatriots say, well, you're never going to see somebody who's LGBTQ. And I about lost it. I was like, we're learning about things that are incredibly rare. This is not one of those situations. And so it started off with analyzing our exposure to healthcare related to LGBTQ patients and their unique health needs, and analyzing our curriculum, finding the gaps. And so I really dove into medical education through that route. Moving into endocrinology, after my first year of medical school, I had the chance to work with some phenomenal researchers and clinicians at the Barbara Davis Center and Children's Hospital Colorado, and was really introduced to the concept of endocrinology, which is the study of all hormones. And I think hormones can sometimes get a bad rep out in the universe, but I think listeners need to remember that hormones are just messengers and messages moving about our body. And this is how I explain it to my patients. If they're teenagers, I'll say they're text messages. But they're just messages moving throughout our body, telling it to do things. And so once I learned more about what this field was going to emphasize, and that it kind of functions as a game or a puzzle, there are these complicated pathways of all of these different hormones. And endocrinology is really figuring out, okay, this is where there's a difference, or this is where there is a problem, or this phone is not able to receive this message. It really is okay, where in the chain did something happen? And the majority of the time, like 90% of the time, I can do something about it, which is really unique and special and part of what drew me to this. As a first-year medical student, I went to a camp for pediatric patients with type 1 diabetes, and I remember being incredibly humbled by the strength and just the spirit of these patients and of all patients living with a chronic illness. But this happened to be who I was, working with and camping alongside. I was walking around the lake one night, and this little girl looked up at me and she said, "I think kids with type 1 are some of the bravest." And I was like, oh, without a doubt. And I knew I wanted to work in endocrinology and pediatric endocrinology specifically. It was this perfect marriage of wanting to be an advocate for, as well as educate on LGBTQ health, as well as get involved in some of the transgender and gender diverse specific care, including like pubertal suppression, hormone therapy. And so it really was the best of all of my worlds. It was a very long there.
That's really beautiful what you're saying. Tell us a little bit more about the highs and the lows, the joys and the challenges you run into, and also if you want to tell us more about the puzzle and how you solve the puzzle, some of these puzzles. What are you doing with the young people who are struggling, and also. You can talk about at the fourth grade level, if you like, because that's where most of us are at, and we certainly need the education. But one thing that I'm curious about, I know that my mother struggled with depression, and she read a book by Karen Horney that helped. But I think this was in the 1950s, and I think the doctors then were prescribing just hormones to women who were menopausal or whatever, thinking it was going to kind of lift their mood. So I think she got large doses of estrogen or whatever, progesterone, kind of for emotional purposes. But I've never known if that really has antidepressant effects. I know the sad thing in her case was when I went to medical school, she had benign uterine fibroids, and decided after great ambivalence to have them removed, even though there was no malignancy or anything involved. I guess there was bleeding and discomfort and so forth. And sadly, after the surgery, she had a saddle embolus that went to her lungs, and she died instantly, which was very sad and very tragic. And I suspect it was probably due to, getting, I think and you would know way more than me because I'm an idiot in this, but I've thought that maybe the large doses of hormones in her case might have been making the blood clot a bit excessively and might have led to that problem.
Well, David, you really just gave me a ton to unpack there. Tell you what, let me start with some of the highs and the lows, and then you're kind of jumping ahead to some of the risks and benefits of proceeding with any form of hormone therapy at any time point for anyone. And so let me address a little bit of the highs and lows, if that's all right with you.
Yeah, thank you.
I think just what I was speaking to earlier, there are such extremes, like the highs are so high. To have any young person come into your clinical space as a provider and give them a chance and an opportunity to be heard, to be validated, to share their experience in a safe and welcoming and accepting environment has resulted in some of the best and most memorable patient encounters that I have had. I've had patients leave sobbing without any form of intervention, just from having a provider, a clinician, meeting them where they are at and hearing them tell their story in a non-judgmental way. And then for some of my folks who do end up pursuing any form of medical treatment, whether it's hormone therapy or even just, a pause on puberty or stopping periods, any form of medical intervention, I've had folks come back and say, this has really changed and improved my life. Some of the more extreme ones are patients who are trans-masculine individuals and who experiencing and dealing with a period results in significant what is called gender dysphoria and can sometimes manifest in such extreme ways as like suicidal ideation, as you said, self-harm, and having them come in after I'm able to basically remove the period aspect and basically just put a pause on dealing with periods. And they say, you saved my life. It's very intense and it's very personal. And to be in a space and a place where I can help someone to that extent, especially any of our teenagers these days, it's a tough time to be a teen. There's so much they have to deal with. And so those are some of the highs, or helping a family connect and recognize that, they are one team. They are one team and everyone is processing the information as best as they can. And people are on different time points and timelines, but that they all are on that same team. They all want the best for the patient. Those are, I think, some of the standout highs that I have experienced.
Let me just get you to summarize that a little bit. I can try to summarize it at a simple level, because sometimes we say things that seem simple to us, and then other people say, "Well, what did she just say?"
Right,
sounded important. But this would be a trans person. This would be a woman by
the best way,
genitalia, who's born with the identity of a man, and so then when she becomes into adolescence and begins having periods, this can cause intense despair and depression. If I got you right, and it's because I'm already learning something. I didn't know that was a big issue, but I can see that it would be. And then you can turn off the periods with hormonal treatment. Would that be giving some kind of testosterone or some kind of anti-estrogen or something like that? What kind of hormonal interventions would help to end that person's period?
Yeah, let me take a step back, because you're right, David. I've kind of jumped ahead of myself. In terms of the best way to think about this, the way I would approach it is that this individual who's coming to me, they were assigned at birth female. Okay, so again, when your listeners think about that process, it truly is okay. The baby is delivered. Everyone in the room looks at their genitals, whether there is a penis or a vagina and labia, and they say, it's a boy, it's a girl. And honestly, we need to move away from those practices, but that is how somebody is assigned their sex at birth. And when we speak to gender and gender identity, again, think of your identity as being this incredibly personal, internal sense of self. Every single one of us has an identity. I identify as a cisgender female, and that just speaks to the fact that my female gender identity aligns with the body that I happen to be born in. And so dysphoria is this, you summarized it quite well, this extreme and life-impacting sense of dissatisfaction, unease, despair, and it often, like I said, impacts people's day-to-day lives. I have some patients where taking a shower is one of the most difficult things because they are forced to see or clean, or at least clean, the body that does not align with who they are. And so dysphoria is, in my experience, and when patients describe it to me, this overwhelming force that impacts the way they move through this world. and leads people to try to do anything within their power to have their body align with who they are and their identity.
Rachel, can I jump in for a sec?
Yeah.
Having you define these terms is really helpful. In terms of the highs and lows, you had mentioned helping the family connect, and I imagine that there are highs and lows with the parents or guardians and the siblings. Mm-hmm. Do you work with the whole family, and could you talk about how that impacts your patients?
Yeah. So I definitely emphasize viewing my patient as a whole human. This is definitely all-inclusive care. I'm considering their medical history, their family's medical history. All patients under 18 come to their visits with their legal guardians. And it ends up being a whole family affair. And I like to say, I take the patient's name and I say, all right, we are now, and I'm adding myself, but we are all now Team Jasper. Pick whatever name. We are all part of this team. And it is my job to make sure that you all have medically accurate information in terms of moving forward with any form of care. And honestly, as you said, there are some really extreme highs and lows. I have had families where, unfortunately, one guardian actually moves forward with court-based acquisition of medical rights in order to move forward with this treatment. I have had families where there have been significant differences in terms of people's approaches or their understandings, especially when they come in. And so it can be really helpful. I always start my visits with, tell me the top thing that you want to make sure that I talk about or address or help you understand today. And I get that from everyone, not just the patient, because it can be really, really difficult, especially in some of these cases. You know, the patients have been thinking about their gender identity and who they are in a very focused and defined way that their guardians may have had no idea was going on. And so these patients have been thinking or have been talking about it with friends or other individuals in their lives. And then oftentimes parents get clued in further along in the process, and they also need space to go through the process of recognizing and understanding, okay, this is my kid and I love them unreservedly. You know, that can be, everyone has a different timeline, and it's important to respect that, like, people are going to be coming into the medical office at different points in that process. I think one of the highs is when, you know, guardian and patient are able to either resolve or fix what has been a horrible rift in their relationship that has centered around gender identity, or possibly moving forward with any form of intervention around gender identity, and to see people create space to respect and listen and just be there for each other. That's definitely one of the best interpersonal highs that I've experienced.
I love what you're saying there, Rachel, because that's also an important principle that we try to emphasize in our psycho team, coincidentally called, team CBT psychotherapy, is to give the patient a chance to talk at the beginning of the session without being helped. The therapist try to help, and that's hard for therapists to learn to do, to just, tell me more, and sounds like you're feeling X, Y, and Z, and you're thinking A, B, and C, and I can imagine how awful that's been for you, and I really want to hear more. So try to be a patient-centered therapist, listener. And then once the patient feels completely understood, to say, now what would you like to accomplish in today's session, as opposed to imposing our own agendas. And that's oftentimes very difficult. And even on you weren't on the hike this last Sunday, but a young woman was asking for help, and I could see immediately the solution, and suggested that at the beginning during empathy, and I got bitten by a rattlesnake twice. Uh, and I told myself, David, you're screwing up here. Go back to listening and let her guide you where she wants to go. And it took discipline, but I did, and it just ended up a phenomenal outcome with a lot of joy. But what you said just really resonated with me, that you're here to hear from every member of the family team, and to find out what it is they want to say, what do they want to understand, what is their agenda. If I heard you right, and
no, you definitely did. Oh, sorry, go ahead.
And that when people get on the same page and can all say, this is my kid, or this is my brother or sister or whatever, and I accept them unconditionally, and that's really happening, that's one of the huge sources of joy for you in your personal life and clinical work.
Yes, definitely. And I very much agree, David. I sometimes catch myself going into an appointment and being like, oh, and I'm going to offer this, and we'll see what they think about this, having more of that agenda. And especially with my new patients, I've really tried to develop a methodical approach where I obviously introduce myself, I let them introduce themselves, and give them the chance to speak. And then I really try to make it clear that everyone and every patient's and every team's journey is different. There is no one size fits all. I have some patients where the most important thing is having their legal documents align with their chosen name, whether that's birth certificate, license, even just paperwork in the school system. For some folks, it is that social transition and gender expression. So when I talk about that, it's the way that they style their hair, the way they use makeup, the clothing that they wear, these things that are external representations of gender identity. And then for some folks, it is really important to move forward with medical interventions, and some of that can include hormone therapy. And then I have some folks where a big part of their transition and having their body align with who they are is related to like surgical intervention. And so I lay all of these options out and be like, there is no right or wrong. This is the playbook. These are the options. And then what I will have patients do is give them space to tell me what I call their gender journey. When did you start thinking about all of this? Who did you start sharing it with? Tell me a little bit about what their experience has been, because it's so unique. And then I ask some follow-up questions, but then I give patients also the opportunity, and this really helps in terms of thinking about how best I can help support them, or what we may move forward with in terms of medical care, is if you could have a magic wand that allowed you to have your body align with your identity, what would that look like? And it's amazing some of the answers I've gotten, and just giving people the space to verbalize that. I've had patients break down in tears and say, right now, I just want to tear my skin off because it doesn't represent who I am. It's incredibly powerful to just let these patients speak and share, and not have them be immediately attacked or feel that they have to defend who they are.
Yeah, it's such a parallel to what we do, although yours is much more high tech. But we also use that magic wand idea. Like if we had a magic wand and a miracle happens in today's therapy session, what would happen by the end of the session? What change would you be hoping for? And then we're working to achieve that goal. I have a couple. Going back to my fourth grade self, and your goal of educating, we're a great audience because I'm very uneducated in this area, I have to confess. But let me, I have two questions kind of related. We've got, first of all, the cisgender or transgender, and that means if your identity, if you're born with a penis and you feel you're a male, then you're a cis, CIS gender. Your gender identity is the same as your biology, and then a trans would be someone whose gender identity is the opposite. So if you're born with female genitals but you feel you're a man, then that would you be a trans male. Is that correct?
Well, and yes, in the general sense, yes.
And so that's the first dividing point. And then the second dividing point is, regardless if you're cis or trans, we have sexual preference, sexual identity. So that can be, if you're have a female identity, whether it's a cis or trans, and you're attracted sexually, that's to the same sex, or if you're attracted sexually to the opposite sex or the opposite gender. Maybe I'm using these words incorrectly, but I think there's these two dividing points, and I'm wondering to what extent, if you know, they're orthogonal to each other, independent, or is there some correlation between those? And secondly, what is the thinking on those two? To what extent are those two thought to be, and there may be no good answers at this time, which is the true answer to most of these questions, but what percentage of that is genetic, and what percentage of that might be due to some biological factors or something happening during pregnancy, or or who knows what? In other words, what are the things that cause our gender identity and then our sexual preference? And if the answer is what is known as zero, I would be not surprised.
I think the most important thing is to recognize that those are very independent aspects of someone's identity. I would refer listeners to go and check out the Gender Unicorn schematic. It's basically a picture of a unicorn, but it helps really present these ideas in simple terms and concrete terms. So the way to think about it is, your identity is, again, that sense of self. That is your brain, that is your heart, that is your soul, that is who you are. Sexual orientation is a very complicated but very separate concept. And so, like, you were bringing up sexual orientation in terms of who people are attracted to. It can be more than that even. It can be who you are physically attracted to, who you fall in love with or emotionally are attracted to. And it can also differ between, just having an attraction and then who you engage in any form of sex with. So sexual orientation and who people are attracted to, fall in love with, and have sex with is completely separate from gender identity. I think it makes a lot of sense why the two often get not only associated, but sometimes confused and mixed. Because when you even think about the acronym for the LGBTQIA+ community, there are pieces of that community that are related to being a minority in terms of sexual orientation. And there are members of that community who are viewed as a minority in terms of their gender identity. And that speaks to like our transgender, gender diverse, including non-binary, genderqueer, agender folk. So it really is these two parts of the community that you're speaking to.
Okay, I love what you're saying and what a great, clear teacher you are. Can I ask a couple more naive questions?
I'm here for it. Go for it, David.
Yeah. So I love that these are orthogonal or uncorrelated. I get to use some of my statistical lingo there and sound like I know something when I don't. And then the two other questions, and I apologize again if these are primitive questions, but I do a lot of statistical modeling. I've been tearing my hair out for the last 3 days trying to get AI to cooperate statistically. But what are the approximate ages that people become aware of their that your identity is not the same as your body? That would be the cis trans thing. What's the age range at which people dawns on them. Could somebody be 18 years old before they figure this out? Or is it everyone kind of knows by the time they're 3, 4, or 5? And then the same on sexual orientation. Is there a huge range of ages at which people discover, my goodness, I'm attracted to men, I'm not attracted to women, or vice versa, or whatever it might be? When do people start to know and start to struggle?
Yeah, I think that the answer to this is that it is compounded and confounded by so many factors. But the way I explain it to patients and families, especially when there are guardians who are trying to understand, they've always identified as this, and now they're coming to me and expressing something different. The thing to know is that we start to develop our sense of self and our sense of identity between 18 months and 3 years old. That is when you start recognizing yourself in a mirror and using me or mine, things like that. And so people can have that sense of self, that identity, start to really be rooted, profound, and cemented at a very young age. Some of that expression is, at that age especially, limited by what is given or provided to them. So you think about the children who are young, who are assigned male at birth and are presented only with blue and dark color outfits, or the opposite situation. It's not that somebody that young can express anything else. I have had patients who have been very young as 4 or 5, who are like, oh, I'm a girl, even though the sex assigned at birth is male. But in terms of when people are able, and not only just able and feel safe enough, and also feel that they have enough of an understanding of their identity to share with the world, that can happen at any time. I will say that there are typically 2 or 3, let's go with actually 3 major time points where a lot of this comes to light, or when people's experiences of growing up in their bodies force them to share with the world. So that I do have those patients where very early on in life, 5 or 6 years old, they are able to articulate, no, I'm a girl. No, I'm a boy, even if that does not align with their sex assigned at birth. Or I've also had patients who are like, I'm neither. No, this doesn't fit. So very young age. The other time point where a lot of people are effectively forced to confront that their gender identity doesn't align with the body that they were born in is puberty. And so it can be very distressing as somebody whose body is going to produce estrogen and therefore have chest or breast development. And for somebody to start to experience that process and then be like, this is not who I am, this feels wrong. And so I have a lot of folks coming to me experiencing a significant amount of dysphoria and distress, what's called peripubertally or around puberty. The other option is, or I shouldn't say the other option, the other common time point that I see is also after puberty has finished, when some folks are then recognizing, okay, I've completed this process of having my kid body turn into an adult body, but it's not who I am. And so then there are a lot of folks who will seek out help, information, and come forward with their gender identity at that time point. I think the thing to recognize is that for a lot of my patients, when I ask them their gender journey, especially my older patients, they're like, I have known that something is different, that I'm not the same as my friends, and they often are quoting me many years. But getting from the time point where they recognize that to the time point where they share that with friends, family, anyone else, that journey is its own unique thing and can take as long or as little amount of time as they need. But I also have some folks who say, I didn't tell anyone until I turned 18 because I didn't want to be kicked out of the house, or I didn't worry about finding food. There's a lot of social and cultural things that play a role in terms of timing of expression of their gender identity and sharing that, outside of just what's happening from a neurodevelopmental standpoint.
David, can I jump in for a sec?
No, I was going to ask you to take over, actually.
You're doing really great, and you're asking questions that that I'm thinking of too, and I think all of our listeners are going to be thinking of. And Rachel, it's just incredibly helpful to listen to you. I'm reminded of a client that I had who was a freshman in high school who came to me not because of any gender identity issue, but after we dealt with their presenting problem said, oh, by the way, I'm trans and I want that to be the part of our focus now. And because it's not something that I'm super familiar with, I sought out some supervision, which was really helpful. She didn't want a new therapist because we had already dealt with other stuff in their life. So I'm looking to you for guidance for other therapists and me if it happens again, that if we're working with a teen or young person who says, oh, by the way, what I want to work on is my identity, how best can we give them gender-affirming care?
Yeah, that's a really great question, Rhonda. And I appreciate that. It makes a lot of sense to me that you found yourself in that position. And I think it happens quite often where primary care doctors, as well as primary therapists, where, that may have not been the initial emphasis or focus, then find out along the way in terms of the patient comes to know them and trust them and has been working with them, shares that there is this aspect of their gender identity that they want to either explore or want to share with you. And it can be pretty overwhelming. I think one of the best and most important things you can do is honestly take your cues from them. If you have a patient who is coming to you and they start using different pronouns, approaching it with curiosity and without judgment, and asking them to how do you want me to refer to you? Really coming at it with a share with me about this. In terms of seeking out expertise, providing gender-affirming care can be as simple as just respecting somebody's pronouns, just respecting their chosen name, whether that is somebody who is cisgender, who has a nickname that they live with, and that's their chosen name, or somebody who has basically moved on from what is called a dead name that does not represent who they are. And so there are very simple and very meaningful things that people can do in the moment just to provide support and that space of acceptance and safety. If it's somebody who is coming to you saying, I want evaluation before moving forward with hormone therapy or possibly a surgical intervention, I definitely think it's appropriate and would recommend that individual get involved with a multidisciplinary clinic that has access to mental health clinicians who have been trained and have done extensive work in working with gender diverse patients. One of the things that I always love to offer my patients and their families is, there's only so many people in my clinic who can help do that, but there are a lot of therapists, social workers, and other mental health clinicians who have undergone training and are competent and very confident and very comfortable with providing high quality care to transgender and gender diverse youth, adults, all of these folks.
I know what I would do if I were in the therapist position, which might not be identical to the endocrinologist position. But again, I'm seeing so much parallel with our work because almost all of the patients I see struggle with depression and excessive self-criticism. But we criticize ourselves for a wide variety of things. So each patient is treated very individually and very uniquely. Maybe I beat up on myself because I have social anxiety, or because I'm too tall and skinny, or because I'm not smart enough, or whatever. But the theme of acceptance is not the answer for everyone. That's a bunch of garbage. There's no one answer for everyone, but it's an important answer for most people, especially struggling with depression. And then by asking them, tell me your thoughts when you're feeling upset, and write them down, and then you can do positive reframing and identify the distortions and find ways to talk back to those thoughts. The treatment could be very similar, with self-acceptance being one of the ultimate goals, and one that's very hard for, in my experience, for humans to achieve, because I can think of psychiatric residents who I've supervised at Stanford They were trying to grasp the thing on acceptance, self-acceptance, and, accept yourself with your flaws and not being as smart as you're supposed to be or that you want to be. And how can we accept those things? We're supposed to beat up on ourselves and make ourselves, better and better through self-criticism. And the moment that somebody gets self-acceptance and goes into enlightenment for the first time is just like a watershed moment in their life when you accept yourself for your, below average shitty self. And that's what Jesus and the Buddha all said. Yes, go for it. That's what it's all about. But it's hard for people to get that because it seems like settling for second best. But it's I see a lot of similarity that from your medical position, you're trying to get people to accept themselves and love themselves.
Yeah, and I think this also refers back to what you and I think focused more on when we met on that walk, David, is as a provider, I'm struggling with accepting that I'm enough and that I'm doing enough for this patient population and these wonderful humans who I get to work with. And honestly, a lot of my patients come to me they're at the point where there is a lot of acceptance of self. It's more about how to have those conversations with other people, especially their guardians and family members. And then also, how do we basically affirm who they are? And is there a role for any form of medical treatment? But I'm personally struggling with the acceptance of oneself because this is just such a time of need for voices to advocate and lift up, again, the voices of transgender and gender diverse folk. And I am in such a place of privilege because, well, your listeners can't see me, but I am white, I am cisgender, and I have 2 magical letters at the end of my name for my degree, MD, and therefore I am provided with the spaces and opportunities just like this to share my experience and my voice. And I just want to shout it from the rooftops that I want to do more.
Yeah, well, that's great. You don't need treatment for that. we need more Rachels, to be honest.
Thanks, David.
I had one other question, and maybe we can go back to some of your emotional ride and some of the dark moments for you and for your patients and the bright moments. But I had one other question that you kind of skipped, and it might have been I don't know, and nobody knows. But these 2 big whys on development. First of all, will my identity be cis or trans? And then secondly, who will I be attracted to sexually and emotionally to want to have as a partner? And there must be a lot of opinion, and probably most of it is not based on decent research or honest or clever or intelligent research. But do we have any idea or guess to what extent that might be genetic, or is that a biological thing that we're kind of born with? Are there influences on those things after birth? My hunch about it is that they're just kind of entirely biological, physical, genetic things. But I don't know the literature at all. But it seems so heavily imprinted on us from a very early age. But do you have any feeling what the academic literature is suggesting?
Well, I guess I don't want to take the emphasis too far off of focusing on kind of experiences, but if I had the knowledge of a good way to sum all of this up, I would not have to work. And I would definitely emphasize that somebody's gender identity and their sexual orientation are completely separate. And I think like so many aspects of anyone's identity, and again, there's so many parts of our identity. You know, I identify as a wife. I identify as a triathlete.
Well, I love that your identity is as triathlon. I've done 3 triathlons.
Oh, fantastic, Rhonda. It's so much fun.
Yeah, I know. They're so much fun.
It's like the perfect thing because I'm like good at sports, but I never was the star. And so here was this opportunity to be good at 3 sports and therefore enjoy and be good at triathlon.
Yeah, it's awesome.
That's wow, fantastic.
Yeah, and again, we could dive way deeper into somebody's identity, but there's so many components that play into it. Yes, it's sense of self, biology, like there's so many things. And so, David, you're asking really good questions, and some of them it's just truly that I don't think we know, and to be able to like get it down to the point where we could do a randomized control trial or an effective study would mean we had to take too much out of it. You know, it wouldn't be applicable. It wouldn't have the external validity.
Right.
So.
Right. Well, we'll find answers to these things one of these days.
But there's so many things that play into each of those identities, and it is so multifaceted and complicated. It would be, I think, incorrect to say that there isn't an impact from our environment as well as our biology. But I don't think that I can't sit here and tell you we have found the clear answer. And again, as an endocrinologist, I love to say, here is the etiology or the source, here is the cause, and here is the outcome, and here is what we do to replace it or change it or provide what the body can't make. And there is no way to simplify this. Our identities and our senses of self are just too complicated.
Yeah. So we kind of don't know the answers to those questions yet and have to remain humble and wish more people were humble. Yes.
And I think it all comes from a place of respecting who somebody tells you they are, respecting when somebody says, this is my name and this is what I go by. That is, I think, the heart of the matter is just respect.
Yeah.
I know in the case with the client that I was telling you about, they were very worried about their safety, especially when leaving the bubble of the Bay Area in California. And we spent a lot of time talking about that.
Yeah. And that's a very real concern. I definitely set aside some time in my visits, whether it is a new patient or somebody who is new to me but has been seen by our clinic, and have the very open conversation that I would be remiss if we didn't at least speak to the fact that this is a time of great uncertainty and fear and hatred. And then I go on to share a little bit more about what is happening currently, because again, it's changing all the time, and how that does or does not impact, again, my ability to provide them medically necessary care, and then give them the space to share how everything is impacting them. I've had families be like, okay, if we have to leave the United States, which country should we move to? You know, and really sharing the fact that, yes, there is a lot of fear and unknown right now, but at this time, and part of why I moved to California was to be able to provide the highest quality of care for as long as possible to all of my patients.
Do people come to you from other parts of the world or other states? Are people moving here because they want to work with you?
We definitely have a growing community of what I'm calling medical refugees. I experienced this even in training before I finished my fellowship, where there would be either entire family units or just dyads, so like one parent and patient, who would either move or fly or drive for hours to have access to our multidisciplinary clinic and to have these conversations. And again, so many folks don't proceed with any form of like medical treatment. It's just to be affirmed and to come to a clinic that recognizes and accepts them. And so, yes, that number is growing. The places that they are fleeing or traveling from is unfortunately also growing. And I am very grateful to live in a shield state, but also a state where we have the backing of our Attorney General in such a vocal way. And I expect it will unfortunately get worse before it gets better. I also have patients who are asking me, what happens if you aren't able to write me prescriptions? And they're talking about going to other countries to receive their medicine, or like trying to find things in questionable ways. And I'm like, there's no way to know if that's pure medication, if there is something else that is in that medication. And that really scares me, is people losing access to high quality medication.
So it's so sad to hear what you're saying, Rachel.
Yeah. I think that, I think a lot of it unfortunately comes back to misinformation and disinformation. And I think it's important that people really recognize what that means and where that is coming from. And I looked up the definitions because I have a sense, and and honestly, some of it is just my reaction to it tells me what kind of information it is. But I think that there has been a lot of sharing of inaccurate information, and what delineates misinformation from disinformation is the intent. And so
yes, right.
In misinformation, it is the inadvertent sharing or spread of false information. Generally, there's no intent to harm behind it, whereas disinformation is the deliberate spread of false information with the intent to mislead others and confuse fact and fiction. And when I interviewed here, I was asked what I thought the greatest danger to transgender and gender diverse folks of all ages was, and it was those two forms of inadvertent spread of false information. I think misinformation and disinformation, especially in the day of social media and such connectivity, is definitely one of the most dangerous, and is unfortunately running rampant.
That distinction is where most, but not all, of the hatred comes in.
Mm-hmm. David, when you and I went on that walk, a lot more of it was focused on my struggle in terms of continuing to provide this care and feeling, again, like I'm not enough, like I'm not doing enough for these patients, and wanting to be an advocate, but also having to balance my well-being.
Yeah, I should be doing more listening. I'm just so curious about everything you're saying. A chance to learn a little bit today. But what I just wanted to finish up saying was that my dad was working with Arizona State University students in some kind of, I suppose, whatever function. He was in there in his retirement trying to do some kind of conversion therapy. And it just shocked me and outraged me so much that I refused to be with him when he died.
I can feel it in my body, the rage and frustration when we even speak about the concept of conversion therapy. And so, first of all, I'm very sorry for the loss of your father, but even just hearing about somebody participating in providing what's been misclassified as therapy and was just honestly harmful, you can hear it in my voice. I feel such rage and disappointment and sadness. Yeah. And I have had patients and friends who have not survived conversion and therapy, have taken their own life.
Oh boy. Yeah, I'm so sad to hear that, and so angry. Yeah.
And so it's definitely a pseudoscientific practice of attempting to change somebody's identity that we know doesn't work and only causes harm. And so,
Well, you're a breath of fresh air, Rachel. We just love you and appreciate so much what you're doing, and breaks my heart when you say you're not enough and you're not doing enough. But that seems to be another part of our humanity. So you'll have to come back on another hike, and we'll have to fix you up there.
I am happy to, but yes, I would agree. And yeah, I'm in the office and I struggle. Like, I give so much of myself to my patients. I come home to my wife.
Yes, you do.
And and it's like there's nothing left. And so I'm still trying to find that balance, but yet also still, as I said, feeling overwhelmingly like I need to do more. I need to be a better advocate. I need to be more careful and appropriate with my verbiage and with the messages that I share. And it's tough.
Yeah. Well, I think you're doing just beautifully.
Yeah. We've been on the podcast for an hour.
Oh, yeah.
And so while we're going into a really great direction,
we'll have to make that a part two.
Rachel, I was just wondering if you want to come on for a part two, just what David said, to talk about the incredible thoughts that you're having now that we could support you to overcome, because your articulateness about this subject has been a real breath of fresh air. And I've learned so much from you. And it's really helpful and interesting.
Because I've been sitting over here and I'm like, well, I might have phrased that differently, but it's also, I want to share my authentic reactions, and sometimes those are imperfect. And this is definitely me sharing my personal experience as somebody who is on the front line and seeing these patients and these families and the fear that they are dealing with and the struggles. And so if I'm able to help folks understand even a bit of what that is, that's amazing. So I appreciate you saying that. And the answer to your question is, Rhonda, I would be happy to come on again.
Okay, wonderful.
Rachel, it's been such a pleasure and an honor to have you be on. Thank you so much. I'm sure you're super busy, and we appreciate you taking the time out to be with us.
Are you kidding me? I've been looking forward to this all week.
Thank you. Next time we're going to meet, there's a local mountain here, and we're going to meet on the mountaintop so we can shout.
Okay.
Definitely.
We'll get public television from San Francisco to come and cover the event.
This is something I'm really excited to be doing, and I really appreciate the opportunity. So thank you both.
Oh, thank you so much. We're honored.
This has been another episode of the Feeling Good podcast. For more information, visit Dr. Burns' website at feelinggood.com, where you will find the show notes under the podcast page. You will also find archives of previous episodes and many resources for therapists and non-therapists. We welcome your comments and questions. If you want to support the show, please share the podcast with people who might benefit from it. You could also go to iTunes and leave a 5-star rating. I am your host, Rhonda Borowski, the director of the Feeling Great Therapy Center. We hope you enjoyed this episode. I invite you to join us next time for another episode of the Feeling Good podcast.